You were looking at training and development and how that should be organised in the future.
Yeah, I think we reached a pretty straightforward consensus actually. I think it's worth remembering the NHS probably spends more on training and development than any other organisation in this country. You know, if you take into account doctors, nurses and everything else. And we're pretty regulated in the way that we have to provide that training. So, and then when you look at managers, we're not sure of the date, but some form of management training actually started in the 1950s. It was training for administrators and hospital secretaries and that sort of thing. That has evolved over time. We've probably got one of the best thought of management graduate training schemes in the country, way oversubscribed every year. So, you know, that works, got a good track record there. I think the issue around all forms of management training is everything is optional, and I think we've got to, as an organisation, do something about allowing it to be optional. And I'm talking, I can go from, you know, band 7 ward managers right through, you know, sometimes we put band 7s into a ward and, you know, we then start to give them the management training that they should probably have had before we put them in the position. So it goes not just chief executives and chairs and that sort of thing, it really is down through the organisation. And we were concerned as to what the outlook will be for the next few years, because the NHS is going to be under immense financial pressure. And I gave the example of, you know, when I go through cost improvement programmes, coming from people midway in my organisation, you know, there's one thing I always look for, the one that's about to raid the training and development budget and put it forward as a camouflaged cost improvement. So you throw that one out. So I think we were pretty clear that in terms of NHS management, I'm talking about, you know, there's good HR training schemes, there's good finance training scheme and general management training scheme. It's all there. Problem is, it's optional, and I think we've got to take away it being optional. And it doesn't matter, you could be appointed to a chief exec post because you've had the relevant experience, but then it shouldn't be optional for the next few years whether you have that management training or not. We're also very strong on all of this training probably requires absolutely no more putting in place to evaluate whether it's good, bad or indifferent. We've been doing that for years. It's competed for by all the academic institutions in this country. And if someone's got a concern about the standard that, you know, Manchester Business School or Warwick University is delivering, by all means go and get someone from Yale University to give it a once-over to see how it compares in terms of its delivery by international standards. And I don't know the answer to that. In the case of non-execs, we were of a view that the Appointments Commission provide training. There are a number of independent organisations that provide training, but again, our feeling was actually that the vast majority do take up that training. And then I made the point that training really does need to change, and that will be as a consequence of the mid-staff's inquiry, because we're probably training them for the wrong things. And I made the point earlier, you know, about when I had 4 accountants on the board, they needed some training on certain things, and now we've changed. You know, we've got to train for purpose of what a new agenda is, which, as Anthony has said and a number of others, very focused on patient safety and outcomes for patients and not where we've been. Governors, again, there is plenty available for them, and again, take away the fact that it's optional. We came to the conclusion that there has got to be a mix between trust, training and development, because every trust has to have a training and development department to deliver middle management training and all those sorts of things. That works okay. And then in whatever the new regional structure looks like, again, there is going to be a role for bringing training together at a regional level, because we've got some very good developing leaders courses that are done at that level. And quite honestly, trusts are not big enough to be able to pool it or get the expertise. And then we've got some excellent examples of national training that takes place. But it is, I'm being told, spasmodic across the country. I'm told the Northwest is top of the tree, and I think it was East Coast is not very good and buys everything from the centre. So there's got to be...
We'll edit that bit out.
Edit that bit out.
Put that one on Twitter.
No, we were just making the point that it is different, and the North West are very proud of their long track record of how they've approached it, and other places are in a different place. And I think the West Midlands, where I come from, is probably somewhere in the sort of middle. So it's got to be a case of a mixed economy.
Thank you. The key point I think we're hearing from you, the training and development is there. It's pretty good. The NHS should be proud of what it's got, but this is a question about whether this training and development should be optional for managers in particular. Is something that needs looking at.
Can I just ask this question about, I know that Robert quite often rambles on about, and I'm having a particular go because he's a lawyer, so...
He doesn't ramble.
He does, he rambles on about the staff academy issue, and it would seem that having a clear set of very good, you know, training, development, learning things would be quite appropriate for a good staff academy. I mean, that's effectively what the graduate training scheme is. Is that not something we could apply to the rest of the NHS, really? That's the, you know, and actually develop leaders in a very clear way rather than have this sort of quite diverse approach.
Of course, we have had iterations of that before. We're not.
I agree with that, actually. I think, I mean, it's nice to hear that people saying good things about training and development, but I think we can always do better. And I think the fact there is a competitive market does help, actually. So we are competing. But I would say we need to make sure we're training for the right purposes. And so that's important. I do think that we do privilege to some extent the graduate management training scheme, and it's absolutely excellent. And in years gone by, there was quite a good national initiative on middle managers, the National Management Development Initiative, and that went by the board. And that was a real shame. So I think as well as the argument from this table that ongoing management training of some kind should be mandatory, there should be evidence of that before you get your promotion. I think also there should be a bit more systematisation actually as you go through, because very often people will argue that part of the problem with the NHS is not at the top level, not actually at the graduate entry level, but actually those middle managers who have probably the hardest jobs of all in the NHS. And again, the inverse leadership law probably have least access to high quality training.
Okay. All right, so a point there about the competition, having different providers actually has improved the quality, so I'm not sure that fits with your academy notion. Any other points on this, should training be mandatory?
Thank you very much. Yes, of course, I think we can all benefit from training. But if we look at the particular focus of this inquiry, which is to do with patient safety, perhaps it's important to recall that as far as we could establish at the parliamentary review on patient safety, we have not got an improving landscape. And since the Bristol inquiry until now, and not only in the UK, we have rates of patient harm which hover stubbornly around the same figure in developed countries of around 10% of all admissions. So there must be something that we are doing which we should do better, or there must be something that we're not doing that we should do. Now, having spent over a decade researching the way in which my particular discipline has failed to perform well and trying to improve it, doing a series of research projects and training enterprises, some of which have worked very poorly, I have to say, although we've learned a lot from it, there's no doubt that a wider understanding of the underlying ingredients of treatment failure and the methods by which they can be reduced or eliminated is absolutely crucial to good management, whether it be by clinicians or full-time managers. And in that agenda, the introduction of appropriate human factors training and safety science training, which has been advocated by a number of professional groups and pressure groups, but to be frank, has been resisted by senior members of our own profession, because they cannot conceive perhaps that there are things about their training which were insufficient for today's complex world, is a deficiency which we should remedy. And in terms of the leadership structures and programs we were shown today, I fear we have heard too little mention of the core values which we should continually iterate. Because as Maxine has reminded us, if the care isn't good enough for us or members of our family, it's not good enough. And that's the criterion which we should apply. Similarly, in patient safety terms, we have to do the very best we can. A point was made earlier on that the pressures which come onto managers, for example, the 4-hour wait, the 18-week target, are such that they may degrade the attention which is available both to clinicians and managers to focus on the important patient safety issues. Well, as part of our improvement methods, we have organised conferences in which we've asked leaders from other industries from a wide variety of backgrounds to tell us how they manage those competing risks. And for the benefit of that questioner who claimed that there was something more important to do, I quote the words of Chris Allen, who was talking to us about the revolution that occurred in the offshore oil industry following Piper Alpha. And he put it quite simply and helpfully to us. And he said, if safety were our #1 priority, we wouldn't be out there, because the North Sea is a dangerous place. On the other hand, when we are out there, if there is a conflict between the safe management of our operation and the production, safety trumps. And that's the attitude we have to take. Clearly, we are concerned about money, productivity, and so on. But where there is a conflict, safety must predominate. And surely, if there's an essential lesson to the discoveries in Bristol, reiterated in other inquiries, and particularly in Mid-Staffordshire, it is that unless we see our jobs and our values through the lens of patient safety, we are missing the most important focus which managers and clinicians should have.
It's interesting that you highlighted this, the trends in safety, and that's not an improving direction. I wonder what if we correlated that with investment in training and development, whether we would see a linkage.
I'd very much agree with what's been said about training and sort of removing the option. I think one thing to bear in mind, there is a very big difference between training and competence. For example, you can train people in manual handling, doesn't mean say that they're going to be handling patient safely in practice. And, you know, I think we've got to emphasise the need to actually always measure and monitor to ensure that in practice the right things are being done and that people are clear about their roles and responsibilities.
Thank you very much. Last point over here.
Yeah. Thank you. I just wanted to reiterate the point that we made a little bit earlier around the culture of the NHS and organisations responding to training, because we can train people, put them on courses, development programmes. The management is a discipline that cuts across multidisciplinary teams, multi-professionals, and at multiple levels. So it's a lot about the mindset, making sure we learn from the research that has been done on engagement and linked to high-performance organisations. Otherwise, the investment in training just won't get the return.